Hello and welcome to another episode of Plastic Surgery Unfiltered, a podcast at the intersection of healthcare, business, and the beauty industry. I'm your host, Dr. Armando Davila, and I'm joined by my faithful co-host, Dr. David Turer.
Good morning.
How are you today?
Great.
Today's episode, does faster mean better? When surgery should be long and when it shouldn't. How long should surgery take? So I think that one of the things I wanted to talk about in this episode is one thing we do here that's pretty neat is two things. I think team surgery, which we'll talk about later, and then the fact that we can combine a lot of procedures quite safely in an outpatient way. And, you know, patients ask, well, how long will my surgery take? And let's start why does it matter? Why does surgical time matter to you?
Well, I think that it's, in a lot of things, when we look at the extremes, that they're not great, right? Doing something so quickly that it feels rushed or is not of good quality, I think most people can appreciate why that's a problem, right? Now, taking a really long time to do something can also be a problem. This isn't working in a wood shop where the piece of wood just kind of sits there. We're operating on a human being. Mm-hmm. I mean, I think there's pretty good data out there that once surgeries start to exceed certainly 6-7 hours in length, the risk of complications starts to go up significantly.
Yeah.
And so, obviously I think, that's retrospective data. So there's probably some confounding factors there as to why the surgery was longer, it was bigger, more complicated, whatever. But I think we know pretty clearly, we really shouldn't be doing 10, 12-hour cosmetic surgeries.
Right. Yeah, absolutely. I mean, this paper, there's a pretty good paper by Dr. Kenkel out of UT Southwestern. Your buddy,
one of my mentors,
one of your mentors, and it was a retrospective look at basically global morbidity and complications. And I'm not going to go into every nitty-gritty part of the detail of the paper, but there was definitely this kind of inflection point that starts around 4 hours, and then it kind of really shoots up at around the around 7 hour mark, right. 6.8 I think is in the paper, and you start to see a 5-fold increased risk of morbidity at that level. And when we start thinking about that, what are things that actually kind of are dangerous for people?
Right.
When we
well, I mean, I think we can use the example of our experience here in Pittsburgh of something like the total body lift. Okay. Right. That's a great example. When we were, or there were surgeons that were pioneering some of these big body contouring procedures after massive weight loss, the thought was, well, let's just do it all at once, right? Use some of the concepts that we talked about, team surgery, you'd have a team of residents or, co-surgeons to get this done. But what we found was that people didn't do great. That you had things like significant blood loss, and some of those patients required transfusion. And there's even just from transfusion alone, there's complications associated with that. So it's not just give them some blood. Mm-hmm. Other medical complications, pulmonary, DVT and pulmonary embolisms, healing complications. It's like my experience in burn surgery, when someone has a 60% TBSA burn, you have to put a feeding tube in to give them enough nutrition to heal. And if you're operating on every part of the body, that patient may just not have the resources to heal. Yeah,
absolutely. And so, it's I think that obviously the DVT risk is one of the biggest, right? It's the why abdominoplasty continues to be one of the most dangerous of the procedures. BBLs are fat embolisms, but emboli of any sort are obviously very dangerous for stroke and other things.
I mean, I would say in our world, it's probably the single most common fatal complication.
Yeah. And so those risks start to really go up as the longer you're in the operating room. And so that's why we've all but abandoned,
particularly under general anesthesia.
Yes, exactly. But we've all but abandoned this concept of the total body lift because it just gets too long.
The total body lift as a single operation,
entity, single entity. Yeah,
exactly.
And so, now there's two parts of this, right? There's obviously procedures that extend, and we'll talk about combining. Well, let's go ahead and talk about combining procedures right now. I mean, why do you think that patients want to combine procedures?
Well, I think there's a variety of reasons. I mean, I think cost is a big one. They think that doing it all together will be less because you don't have multiple rounds of anesthesia, which is legitimate to some degree. Convenience, right? You only have to go through one recovery if you do this all at once. I mean, I think to me, those are probably the two biggest things. What else do you hear from patients?
I mean, I think time availability, I think, is another big thing, right?
Sure.
Especially when you look at patients who come in with lots of weight loss and you start to individualize each procedure. I have to do my arms, I have to do my legs, I have to do my breasts, I have to do my face. It gets to be like 6-7 procedures. It gets kind of crazy. I mean, Ken Cole in the paper showed that I think the average number of procedures was about 4 to 5 procedures that they would combine in some of these longer things. And so, plastic surgeons are good at kind of melding things together.
Well, I think that kind of goes to our reconstructive experience. I mean, how many times were you, let's say in the head and neck reconstruction, the ENT head and neck team was doing the resection up top. We were getting the flap ready. You worked as, there were sometimes 2 or 3 teams on a single operation to make sure that operation didn't get to be 24 hours long.
Yeah, I think that the team thing is super important, right? Like, we really believe in team surgery here. And so, we have a team of very qualified PAs who we've trained, and we do have residents sometimes. I think that residents have their kind of place, and we really believe in education here. But a PA who we've hand trained to kind of anticipate certain things. I call it like we're like the conductor in the orchestra, and then like the PAs and everyone's sort of moving around, right? So they can do parts of the closure, and they can like expose part of the operative field, and they can retract, and they can do all these things. And when patients go and we don't really have that here, but there are some patients I've heard who will go and say, well, are you going to do every single part of the operation? Right. And I mean, I can acquiesce that request, but then you're going to get like one thing, and it may take 2-3 times as long. Yeah. I mean, I think people misunderstand the PA role because they're, probably day to day used to seeing PAs in like primary care offices. But like when I was in training, there were PAs, for example, on the cardiac surgery service who would, crack the chest and basically get the patient on pump before the cardiac surgeon came in with the resident. Yeah. So, I think people misunderstand what the scope of a PA is a physician assistant. Like that can cover a huge scope of practice. Yeah. And they're quite talented. And again, their training is just shy of medical school training, and they don't have the residency component, which means that the way they clinically orchestrate is a little bit different. But they are very talented individuals and immensely capable. Yep. And so, we utilize that a lot to be able to execute some of these more complex operations. And well, like, why don't we talk a little bit about, maybe you could talk about some of the surgeries that we do after massive weight loss. Sure. Like maybe go head to toe. If in someone that's lost 200 pounds, what would you say are the most common procedures that we see? I mean, again, at 200 pounds, you're going to be talking about the potential for global surgery, right? So let's start with the extremities. I mean, brachioplasty and thighplasty, right? Sure. How long should those procedures take? We execute them in around 2 hours apiece. Probably 1 hour is too fast, right? Probably. Yeah. You've got important nerves to both extremities. If you're not thoughtful about the dissection pattern, you can get lymphedema. You can get a lot of kind of problems with that. And wound healing issues if you don't get the, in both directions, get the kind of tension right. And even then, when you get it all right, there's still a lot of things that can happen. If that surgery, if I'm completely alone, right, probably could take me into the 3 hours a piece. Yeah, I think that's probably about right. Yeah. And now when you're getting into 4, that surgery is probably too long. So if your surgeon's quoting you 4 hours for a brachioplasty or thighplasty, unless like a relatively straightforward one, then you're probably on the long side. Right. And certainly our PAs are able to kind of prepare the field, get everything ready for excision, and then I can do excisions, keep moving, then they can do closure, and we can move through 4 extremities within 4 hours pretty readily. Yeah, I think that's pretty routine in our practice here. And, again, without the help of our assistants, we wouldn't be able to execute that. Yeah. I don't think I could offer that procedure at the same time. Correct, yeah. And so what about let's move to the other end of the spectrum. What about something like a breast dog? Yeah, I mean, I think this is like the extremes. You probably know it when you see it. A 10 or 15 minute breast dog might be a little too fast, right? Yeah. A 3 hour breast dog is probably too long. Yeah. I mean, I think we have a really great system here of planning. And so when we go in the operating room, we have a really good plan. For a primary breast dog, the patient knows they chose the implants, so we know exactly the implants we're putting in.
We have a really good system of executing on that operation to make it reliable. And, we're usually in and out of the room in under an hour.
Yeah, I mean, the patient, I tell this line to everyone on breast dogs. It's like, most of the work that we're going to do for your operation is being done in this room right now.
Most of the thinking.
Yeah, the thinking.
Exactly.
Yeah. And so, I mean, I cannot believe that this day and age, I'm still hearing patients being like, oh, well, they didn't tell me what implant I was getting, and they didn't tell me what was going to happen in the operating room. And, we don't have a consignment here, but I think consignment is like double-edged sword. It makes surgeons lazy, that they're just going to pick something off the wall and decide for the patient what they're going to look like.
I mean, if you don't have a good process to let the patient make that decision, sure, maybe that's all you got. But sure. I mean, I think we've come up with a really beautiful system to put our patients in the driver's seat there.
I mean, that's not that's also the way we've structured it. But this isn't like our system. We're not making this de novo. This is backed by 20 years.
Yeah, I learned this system virtually identically in fellowship.
Sure.
Right.
And whether or not you use the high five or whatever the name of the system is, I think that doing patient specific planning is if you talk oral maxillofacial surgery, you talk craniofacial, everyone knows that being patient specific is the way to go.
I think, again, let's get back to talking about reconstructive surgery, right? Now when people do deep flap reconstruction, what do? You get a CTA so that you know exactly the perforator you're going to go for. Yeah. And it has significantly cut down on the time to do those procedures.
Sure. Those were 12-hour surgeries.
Right.
We do them in 4 or 5 hours sometimes.
Exactly. Yeah. Because you have a plan. And so I think that is key, especially when we're talking about these complex, multi-part surgeries. Going in with a specific plan so you know what you're going to do, so that you're not, again, it's not about rushing. It's about being efficient. So you don't want to waste time.
Right.
And if you don't know what you're doing when you go in the operating room, you're going to end up flailing and wasting a lot of time.
I mean, what is for people who are not in the operating room, right? Flailing in a breast dog is you go in, you didn't actually take measurements, you don't actually know the implant you're going to put in. So you go get sizers off the back table.
Right. You're sitting the patient up.
You're sitting the patient up
crooked,
10 times.
It's just...
You're putting in 4 implants, 5 implants. Then you end up with one size, one the other size, and then the patient comes back and is like, well, this isn't what I was wanting.
Well, and how many times have you heard patients come in and say, oh, I saw on TikTok that, recovery after breast augmentation is brutal. Submuscular breast augmentation is so painful and people are miserable for weeks. It's probably because you've caused so much trauma by putting sizers in 5 times and manipulating the breast, and you've been in there for 3 hours that, I get it. Of course that's going to be uncomfortable.
Yeah.
But, the way that we do it, it's people ask, they're like, well, is the recovery different? I'm like, not really. It almost doesn't matter which breast dog where you put the implant, because we're very efficient at executing on it, and people just don't have that much discomfort. So there are multiple downstream effects of that efficiency.
Yeah. So I think that's important, and so, okay, that's that one. What are some other ones?
Yeah, I mean, I think another big one that cases that tend to run long is a face and neck lift or facial rejuvenation.
Oh yeah, this is okay. I'm hot on this one. So yeah, if your surgeon says your facelift takes 2 hours, no, they're not doing something. And this, I don't want to get too much into the nitty gritty. We've done an episode on planes, but I think that people are finally starting to learn that if you just kind of yank on someone's skin, they look
not
pulled.
Great.
And you can still do SMAS procedures by lifting the skin and then just yanking on the SMAS. Either way, you're just yanking on something, and you're not really doing a thoughtful release and repositioning. And people are finally coming around to them. I'm very happy about that on social.
Right.
And so it takes longer than 2 hours. Imagine it's your face.
I mean, I think it's illustrative, right? We were at Baker Gordon a few months ago, and you have Tim Martin doing a facelift, and he's arguably one of the best of course, he's one of the best in the world, or he wouldn't be there presenting. It pretty much took him all day.
It took him the entire day.
And I mean, I'm sure the patient's going to look incredible. Yeah. But, it's quality sometimes takes time.
Yes. Again, in the face, you have nerves and you have all this sort of stuff, and there's confusing nomenclature, right? Because, again, your neck can look better when you do a facelift because they're all connected to each other. But doing a neck is also a separate thing, right?
Yeah. And most of the time when you do a facelift, you also do a neck lift. Well, almost always.
You can do. There are surgeons who do not, right?
Sure. And
then people have incisions because they base their belief on the surgery being done related to the incisions, which don't always match up. Right. And so a neck lift was not done, and that's the most common thing I see. People come in, they have a facelift, they're unhappy with their neck, and I go, well, you didn't have a neck lift. And they go, well, the surgeon said, oh, how long did your surgery take? 2 hours.
Right.
Okay, well, there you go.
Yeah, I mean, it's the difference between a procedure and a comprehensive plan, a comprehensive rejuvenation.
So like probably for a facelift, you're probably wanting 3 hours minimum.
I would think so.
Minimum.
I mean, I'm sure there's guys that can execute, a reasonable facelift in less time than that. But, if you're talking about a 45-minute facelift, like you're probably off base there.
I mean, that's just like way off. Even a 2-hour facelift, I think you're probably not getting what you think you're getting.
Yeah.
So like somewhere in the 3 hours, probably the least. 4 hours is fine. And then when you start combining neck lifts, which also take 2 to 3 hours, you could be looking easily at like a 6-hour procedure plus. And if you're doing anything else, fat grafting, bleph,
bleph, brow lift, fat grafting, all these things.
Now, we just talked about how dangerous going over 6-7 hours is. Right. And then, what is our answer to that problem there?
Yeah, I mean, I think that obviously, like, again, part of this is the planning. Like, again, these are elective procedures. And so I think that things can happen. So, surgery can run long. You can run into unexpected things, of course, and that happens sometimes. But, if you're planning for a 4 or 5 hour procedure and it goes to 6 hours, I think that's okay. If you're planning for an 8-hour procedure and it goes to 12, like, that's a problem.
Yeah. And I think that like when we know that we're going to have a procedure that's a little bit longer, right? Again, we tend to not really schedule anything longer than 5.5, 6 hours because it can run long. We do a lot of preventative things for blood clots and other things. We try not to paralyze the patient, reduce the rate of blood clots. And then, and my personal favorite thing to do is I do a lot of these surgeries awake.
I mean, the one like facelift in particular is a great procedure because it's easy to numb and the patients will tolerate it. I mean, there's certain things, body procedures that you're not going to be able to do awake. Yeah. And so you have to be thoughtful about that and stage them. But you're absolutely right.
And so I can reduce risk sometimes for people because of still doing that, and we can do it safely or do it under a MAC or something a little bit less invasive.
Yeah.
What about how about mommy makeover, like abdominoplasty? Mommy makeover?
Yeah, I mean, I think, well, so just to define what mommy makeover is, because I think that there's a big misconception about that. There is no defined definition of mommy makeover, right? It typically is some kind of breast surgery with some kind of torso or abdominal surgery. The most common thing would be maybe a breast augmentation with a lift with an abdominoplasty and then probably some liposuction. Okay. So, I think, again, it really depends. And we've talked about these like classes of weight loss or classes of laxity. Most of the quote unquote mommy makeovers in women that have had children that haven't had significant weight loss, I mean, you can do all that at once pretty easily in 6 hours. You know, maybe it takes you an hour to do the liposuction of the waist with them prone, flip supine. Again, working as a team, we can easily do a breast augmentation with a lift in a couple hours and abdominoplasty in a couple hours without cutting any corners. Yeah. So you're looking at 5 to 6 hours.
Yeah, 5 to 6 hours.
And again, I think that that's safe certainly to do as an outpatient. And in fact, I think there's probably benefits to doing it as an outpatient because, when you're if you leave a Foley catheter in and you're just laying in bed for 12, 24 hours after surgery in pain, that's how people get DVTs.
Yeah. We'll get to that, I think, in a second. But what about like, what do you think is the shortest
mommy makeover?
Like when it's too short?
Well, I mean, again, it depends. It depends on what you're doing. Sure. If you're doing a breast augmentation and an abdominoplasty, then maybe you could talk about 3 hours. Yeah. Right. But if you're talking about lipo, breast augmentation, lift, abdominoplasty, and you're looking at a 2-hour surgery, I just don't see how that's possible without cutting some corners.
Yeah, I mean, like again, those are when the patient should start looking at some red flags, right? If your surgeon's saying I'm doing a lift, I'm doing a tummy tuck, I'm doing a breast aug, I'm doing some lipo, and they go like, oh, it's going to take 2.5 hours. That should send up warning flags. It just shouldn't like take, again, the shortest an abdominoplasty probably not a mini. It's probably about an hour and a half.
60 to 90 minutes.
60 to 90 minutes. Yeah. And then, we talked about the breast aug and lifts can vary because you can use, smaller lift, larger lifts. There's a lot of variance in lifts, but somewhere in that kind of hour and a half to 2 hour range is pretty average. If your lift's taking 4 hours, not great.
Or 6 hours. Yeah. You're kind of wondering what's going on. Yeah. Again, like it's all in the planning though. I mean, of course we make adjustments on the fly, but like we have a process. So if, an augmentation mastopexy is a relatively complicated procedure. You're making the breast bigger and also making it smaller. So if you don't have a good process for that, you could spend a lot of time fussing.
Yeah. I mean, like, I remember when I came here, when I first came to Pittsburgh and I started at this practice, there was this kind of push to operate too fast. I remember the computer system didn't actually even have times in it. And so, I would see these operations like, we're going to do your arms, your legs, your breasts, your abdomen, 4 hours. And I was just like, there's no way that's happening. And one of two things would happen. Either they'd get finished in 4 hours and it would be not great. Good. Yeah. Bleeding complications, problems, right? Because corners were cut. And then, or it would take 8 hours and it was just like all over the place. Right. Again, our system now is completely programmed in. Like, we don't even decide, right? It's just like set up. And what is our variance? I think our variance is like within 5%
it's really not much.
Our timing.
I mean, look, I think that one of the things that we've done here that's been really cool is that we have unified the way that we do a lot of things. And so it isn't just a Dr. Davila or a Dr. Turer process, it is a PCPS process. Yeah. And so the patient experience is pretty similar regardless of who they see, because we've worked on that together to make it as as efficient and as effective as possible.
Yes.
And so, and again, like, the PAs have been trained by all of us, so they have the exact same experience. So the team is really good at consistently executing, and I think that's what's important. You and I talk all the time about restaurants, right? Like, you're not going to win a Michelin star if one day of the week you make good food and the other 6 days it's crap, right? Like, it has to be consistent.
Yeah, I mean, that's a great point you just brought up. It made me think about something. We do surgery differently, right? And naturally, we have variations on our results and our styles of how we do stuff. But you keep bringing up the planning, and it just sort of hit me that the planning and the system behind the whole structure is the same.
Well, yeah, because the patients, they meet us, and then the team is the one that executes most of the plan to get them to the operating room. Yeah. And so their experience should be identical regardless of their surgeon.
Which is why our times end up very similar, right? Because, again, the idea that this is important, right? Because we're essentially saying that it is not the surgeon necessarily that causes, to a certain extent, the slow or fast surgery. It is the structure around the planning and the system. I
mean, I think as long as the surgeon is competent, or like follows the system, that's true. I mean, if someone, we've all seen them. There's slower and faster surgeons, right? I mean, there may be someone who's just technically slower.
I mean, but again, if someone is so slow outside of like safety range, that's just a problem.
That's a problem.
Yeah. I mean, and also like fast. And again, I think there's some cutting corners, like, right, for cost and stuff. Someone wants to offer someone an hour and a half quick lift and then charges them, a ton. They're banking on
or
that.
Doing them so quickly that, this way I can do 2 more procedures in a day. Like, probably not the right thing to do.
Yeah, probably not the right style. I mean, back to safety, like, one of the things we've done at this office, I'm springboarding off the concept of our system, because I think that the system is what works. And that planning has allowed us to, again, have a near zero, essentially a zero DVT rate. A lot of these problems that happen at 6 or 7 hours, we've managed to mitigate. And like, what are some things that like we do, I guess, here at the office that's made that happen? I mean, like, for example, I know we send people home with like home SCDs. Like, that's something simple.
Yeah.
We Caprini everyone. We don't necessarily, like, one of my pet peeves is that you go to the hospital, you do a 6-hour surgery, they admit you overnight because you're, quote, in pain.
Right.
Now, because you're in pain and you're in the hospital and you're laying in bed because no one's going to get you up, you have a risk of blood clots.
Right.
So they put you on a blood thinner.
Right.
And then you develop a blood clot.
Right, because you increase the risk of bleeding.
Yeah.
Right.
And so now they have a hematoma, and you've just created a huge chain of iatrogenesis.
Right.
And this is where our philosophy of NOVA, full circle, right? Get the person ready for surgery, get them not in pain, so they get home, they walk, they go to the bathroom on their own, they can do all this stuff, and now you've eliminated all that risk.
And of course, I think we're very careful in our screening process to make sure that the people that we select for outpatient surgery, which is almost everybody, are appropriate. If there's someone with a significant medical condition that needs hospitalization for some reason afterwards, we're not going to just be cavalier about it and do them as an outpatient. Right. Like there's a lot of little things, a lot of subtle details, being meticulous about the planning that goes into making this work and making it safe.
What do you think, like, what is your answer to people who ask, well, this surgeon said, they want to do these surgeries split up, and this surgeon said, we can combine them all. Why is there that variance, and why? What should the patient choose?
I think it depends. It really depends on. this is a very individual decision, right? So you might ask why. Why do you do it that way? In our case, we may say, in our experience, doing a total body lift, doing your arms, legs, abdomen, back, breasts, face, all at once is too much. You're going to have a complication. And, they're like, well, someone else said
at least they're going to have a complication in this office.
Right.
Someone might be able to pull that off.
Maybe somebody can pull it off somewhere, right? So based on our experience, we make those decisions. And maybe in someone else's hands, they can do it, right?
Sure.
But if something doesn't feel right, if something, kind of pricks up your spidey sense, it's probably for a reason, right? If something seems too good to be true, it probably is. Now, maybe there's somebody, I'm trying to think of a specific example, right? Like there are oculoplastic surgeons who are masters of eyelid surgery, right? Who maybe that's all they do. And so if you want your eyelids done, maybe it's worth it to go to somebody that's all they do because you feel like you're going to get a better result from them, but you're not going to get your face lift and you're not going to have your neck lift at the same time. And that's okay.
Sure.
It's an individual decision. But again, it's really, I think if something doesn't seem in line with what you expect, you just have to say, like, why are you doing it that way?
Yeah, I think that's a good question for patients to take from this. Like, they should just be really asking. It's not so much that they do or don't do it a certain way. It's that they should have a reason for, and if you get someone that's like, well, my breast dog takes 3 hours, just ask, why is that exactly? Right. And then if they can't really answer, then
it's just something to know.
Yeah, it's something to know and something to base your decision off of. Yeah, I mean, I don't think time. I told that story because I do think that early on in my career, it's like, okay, I couldn't get to this time level, and I thought that something was wrong with me because there was a surgeon, quote, doing it faster. Mm-hmm. And I found out they weren't actually doing it faster. They're just sort of manipulating time. And, every surgeon starts to kind of gauge, I think, where they're going to be. And craftsmanship just takes some time.
Well, and I think as you mature as a surgeon, you also may gravitate towards procedures where, if there's something that you don't do well or it takes you much longer or whatever, then maybe you don't do as many or you don't do that procedure anymore.
I suppose.
We see that all the time.
If they're self-aware enough.
Exactly. Yeah. Exactly. So I think that that's all really important.
Yeah, I just think that, we are, we're under the clock. Like one of the things that I think about a lot is rhinoplasty, right? Mm-hmm. It's like as the rhinoplasty is I call it like a ticking time bomb because once you open the nose starts to get swollen. It's actually, this is true about brachioplasty and thighplasty too, right? Yeah, absolutely. Like once you make the cut, you start to lose the ability to close the arm because the skin starts to contract. And so the longer it takes you to get that incision closed, the more difficulty you'll have, the less likely you are to be tight at the level you want, and then they'll end up with too much laxity or wound healing problems or one way or another. Rhinoplasty is the same. Like you don't have an infinite amount of time, even from the result perspective. And so, it's
a balance.
Carly, is another one that you wanted to know how long a surgery should take?
What about BBLs?
BBLs. Of any type.
That's a great one to talk about.
BBL's a great one, yeah.
Because I think in the height of the BBL craze, particularly in places like Miami, people were knocking out BBLs in 45 minutes. Mm-hmm. But we all know where that led.
Yeah.
Fat embolism, patients were killed. It was a disaster.
Yeah.
Up to the point where the procedure was nearly banned.
Yes, the procedure was nearly banned. And then Florida passed a law limiting the number of BBLs you could perform in a day to basically offset that.
And not be able to delegate certain parts of the operation to other people specifically to avoid those issues.
Yeah.
Now, again, technology sometimes comes along and fixes some of those problems. So guys like Pat Pesmino developed the ultrasound-guided BBL, and so now relatively quickly you can do a very safe and very beautiful BBL.
Yeah, with less time.
In very little time.
But that's a good point, right? Like in a lot of these unaccredited facilities, again we call these the chop shops, which are basically unaccredited facilities being just run by who knows what. The surgeon would run 3 rooms, and you got your BBL for $3,000, and you were like, oh, I'm getting a deal. No, you're not getting a deal. The thing is,
as long as you survive.
As long as you survive. The quote surgeon that you may have met with is probably not even in the room. They have a little army of who knows who they got from somewhere. Right. And, these aren't highly trained PAs that they're having inject you. They're just...
It's another case of If it's too good to be true, it probably is.
Probably is. And, and this is different than travel-based discounts. Like there are fantastic rhinoplasty surgeons in Turkey, and there are fantastic surgeons in Colombia and South America. And, you have to vet them and figure out who they are. But the economy of scale is different there because their dollar is like the exchange rate is favorable.
At least for the moment.
For the moment. But like, that's different than going to Miami. It's the same dollar bill in Miami than it is in
and I don't want
Texas.
anyone to get the impression there aren't spectacular surgeons in Miami.
Oh,
because there's tons of them.
Yeah.
But there's also, like you said, these chop shops.
But they're not charging $2,000, $3,000 for a BBL.
They're sure not, no.
And so, the 45-minute hour BBL is definitely too short. I mean, you need it to at least get the fat out. Again, a surgeon who is worth their salt will also clean or somehow process or rinse or do something with that fat to make sure that it's of good quality, and they won't just sort of pump it back in. And that takes time. I mean, probably 2 hours, I think is like
something
like that. 45 minutes, too short. 4 hours, unless you're doing like a 360, probably too long.
Yeah.
I mean, anything else, Harley? Any other one? I think we covered almost like sort of all of them, and obviously these are for sort of the average individual.
Yeah, I mean, if someone comes in, like not every breast augmentation is the same. If you've never had implants before and this is a primary breast aug, we know exactly the implants we're going to use. If you've had 3 breast augs and have had a malposition and need a lift, and this is tertiary surgery, it's going to take longer. There may be more variability. So all of this is kind of taken with some nuance. But again, that tertiary breast surgery, if it's taking you 12 hours, that's too long.
Yeah, I mean, that comes back to the point that you made, and I think this is really excellent, is that the reason that complex surgery takes way longer is because maybe we cannot generate the plan
as reliably preoperatively.
I'm going to go in there and there's going to be stuff I find that is unexpected or we're not sure about.
Right.
And so now we have to think on the fly. Right. We're good at that, but it takes longer.
Patients may not know what size implant they have. Mm-hmm. And so if you have no idea what implant you have, sometimes we'll bring 2 or 3 different sizes so we have some variability. Right? We can't, I can't necessarily guarantee you that I can pick a specific size beforehand because I have no idea where we're starting.
And then you have to put it in, you have to take it out.
And this is what I counsel patients on all the time because we do a lot of complex secondary breast surgery. That primary breast surgery is much more reliable. Like in secondary surgery, things are a little bit different, and there's some variability that I can't control for because you don't know what you have or what's going on, and so I don't know, and I just can't plan as well.
Yeah. Yeah, I think that's the takeaway for me. It's really in the planning, and I think the structure of the planning is what keeps things tight. And ask why. Make sure your surgeon has a plan.
And if it's too good to be true, it probably is.
It probably is. Thanks everyone for joining us again. I'm Dr. Armando Davila. Dr. Davila Turer joined us today, and join us next time. We have another interesting podcast for you.